Good afternoon, members. It is appointed time and we have a quorum. I call to order the first meeting of the Bills Committee on Electronic Health Record Sharing System Amendment Bill 2025. First of all, I declare interest. I'm a board member of the Hospital Authority and the chairman of the Committee of IT of the HA. Members, is there any objection for my chairing or presiding over the meeting? Thank you. Now, housekeeping matters. Do we need to schedule for a public hearing session? There have been sufficient public consultation beforehand, so we will just invite submission of written submission from the public. We will set a deadline in a week's time. Now, moving on to the scrutiny of the bill, I will first invite the administration to come in. In attendance of the meeting today are Mr. Sam Hui, Deputy Secretary for Health, Ms. Erica Lam, PAS for Health, Dr. Joanna Pang, Chief Medical Informatics Officer of the HA, Mr. Hassan Chan, Senior Manager from the HA, Mr. Melvin Kan, Assistant Secretary for Health, and Mr. Michael Choi, Senior Government Counsel. Now, the government has prepared a council brief for members. The paper has been sent to members beforehand. So please also refer you to paper CB3 540, Assistant Legal Advisor's letter to the administration. A reply from the administration is pending. Now, we will not go through the paper again. We can discuss the bill in earnest. Now, we will start the discussion of the policy matters of the bill now. Members who would like to speak, please press the request to speak button. Since this is the first meeting, I will allow more time for you, 5 minutes for each of you, including questions and answers. Please press the button now. There are 6 members now. They are Mr. Kenneth Leung, Ms. Connie Lam, Reverend Peter Kuhn, Professor Chan Wing Kwong, Mr. Tommy Cheung, and Ms. Judy Chan. 5 minutes each. Mr. Cheung, I have pressed the button already, but it has been switched off. I'm also a member of the Bills Committee next door about the Chinese University of Hong Kong. I will allow Mr. Tommy Cheung to speak first, if that's the case. So they are the members are Tommy Cheung, Kenneth Leung, Connie Lam, Reverend Peter Kuhn, Professor Chan, and Ms. Judy Chan. Mr. Cheung, please. Thank you. I will be very brief. Thank you, Chairman, and thank you, members, for your indulgence. Now, many private doctors, including mine, write their own health record by hand. So with this bill passed, if the doctors prefer writing personal medical record by hand, now for my family doctor, he has been seeing me and my family for 40 years. All our records are in handwriting. It will take substantial effort for him to convert the record into electronic form. The doctor is even older than me. So what will be the arrangement? Will you provide assistance in financial form or in in terms of help to help these doctors convert the medical record into electronic form. It will be a substantial burden for these doctors. And how many years do they have to go back in terms of the conversion? Doctor, please. Thank you, Mr. Zhang. Now, in terms of inputting data into the e-health account, we don't have a mandatory requirement. So for experienced doctors who have a lot of handwritten records, we invite them to digitalize their medical record on a voluntary basis. Of course, to some doctors, they are less tech-savvy. So for the case mentioned by Mr. Tommy Zhang, we agree. We would develop a market comprising third parties providing such services to help these healthcare providers, which are less tech-ready, to convert the record. And also in the bill, when the timing is right, we will consider requiring healthcare providers to upload the medical record into the recipient's e-health account. So the line will be drawn at when this requirement is made. For records, prior to that, we will only require digitalization of very important data. We will not require the veterans to convert decades of medical records into digital form. That's good, but that's not essentially good for patients. So maybe only the recent 2 months of medical record is available, but maybe I have a lot of sickness in the past several decades, so this may be a gap, compromising the healthcare standard for patients. Some doctors may not be able to have access to essential health history. In the future, if we mandate uploading of medical records onto e-health, there will be we will specify certain important health data where doctors will be required to go further in history. For example, allergies of medicine and also recent diagnostic record, or imaging records and pathological checks records in the past year. We may require doctors to go back before the mandatory requirements and give us these records. So there are two principles. First, these are important health data for patients, not all health data. Second, an appropriate time point where doctors are required to trace back. So we will only impose this requirement when there is a consensus between us and the stakeholders. Mr. Kenneth Leung, Chairman, first of all, in terms of the usage of the e-health system in general, now, for this bill, sharing of data is important. There are many stakeholders, including patients, doctors, and other parties. So consent and exchanges of information is very important. Now, there are some 6.1 million people who have registered on e-health. Now, in the perfect world, in theory, everyone in Hong Kong should have registered for e-health. So is there a bottleneck? How can we expand the onboarding rate further? The ecosystem is very important. Second, the healthcare recipients need to change the setting on the eHealth app to allow sharing of data. Now, among the 6.1 million registrants, the patients, healthcare recipients, how many of them do you expect them to change the setting on the eHealth app? People are inertia, so how can we ensure that they will change the setting? Thank you. 2 questions. When will we achieve full onboarding and also the changing of settings? Thank you. There are some 6.2 million registrants on eHealth, accounting for 80% of our population. There's still a shortfall. Now, the major gap lies in the minors. Infants and children have a very low onboarding rate on eHealth. Now, if you look at the demographic structure of the registrants, it is an inverted pyramid. The older the age of the patient, the higher the onboarding rate among the demographic group. That is understandable because elderly people has more medical needs. For children, they are dependent upon their parents and guardians. That explains the lower onboarding rates. That is going to be one of our major works in the future. That is, starting from infancy, we need to encourage parents to set up an eHealth account for the children, where it would be very convenient for parents to set up the accounts for their children once they are born, especially vaccination record. These are very important health data for children. And concerning users of the mobile app, eHealth, so active users, now for downloading number, the number exceeds 3 million. So in the past year, there were more than 1 million active users on mobile platforms. But that's not our ultimate goal. We expect the usage to be much higher. So with the development of more functions on eHealth, members of the public will find eHealth useful in coping with various scenarios. Then the usage rate should go up. It will be an interactive process. So in the 5-year development plan for eHealth Plus, that will be a major goal.
No follow-up questions. I'll wait for the next round. Ms. Connie Lam. Thank you. On eHealth, I support the amendment. As we do so, there are risks that I would like the Deputy Secretary to address. First, it's the risks about cross-boundary data transfer. There's much integration in the GBA. Hong Kong residents access healthcare in the mainland. People use healthcare vouchers in the clinics of the mainland cities of the GBA. So I do have some concerns about data going to the mainland. Now, on patients' rights and informed consent, a patient brings the health records to the mainland, or on the eHealth app, a patient may give sharing consent. My question is, will there be some sort of binding consent? So when you consent to data access for public and private hospitals in Hong Kong, are you automatically consenting to data access for mainland hospitals? Can you opt out? Now, for accredited Hong Kong healthcare providers, they can access a patient's records with the patient's consent. How do we ensure no leakage of patient data in the mainland? Different jurisdictions may be involved in a case, and when data leak happens outside Hong Kong, will the commissioner have the power to enforce the law in the mainland? Once this bill is enacted and a patient revokes the consent, meaning healthcare providers can no longer access the data, how do we ensure that mainland institutions delete the data? Article 44 of the mainland data protection law says institutions can keep a certain amount of data. So when you have a conflict of regulations between Hong Kong and the mainland, what do you do? Now I turn to a question about privacy. Different healthcare professionals will have access to a patient's data, say a lab technician or lab technologist, or you have a pharmacist assistant. What do we mean by the need-to-know basis? So my question is, for different healthcare professionals, do they have different levels of access? Some data are sensitive. Say someone has gone through sexual reassignment surgery, or someone has a mental health history, or they had venereal diseases. So shouldn't we be restricting the access of certain healthcare professionals to a patient's data? So the 4 questions, the first 3 have to do with cross-boundary data transfer. The 4th question is about privacy. What do we mean by the need-to-know basis? Over to Mr. Sam Ho. Now, on cross-boundary sharing of healthcare data, we approach personal data protection with care. When we come to the clause-by-clause scrutiny, members will see that in the clauses, when the commissioner is satisfied that a non-local healthcare institution compromises the security or integrity of e-health, the commissioner will not recognize that institution. And if it's a recognized institution, that recognition can be revoked. So that's an active way for us to ensure the safety, the security of the e-health system, and that includes protection for personal data privacy. Ms. Connie Lam's concern is about access to data and retention of data. We have given thought to these factors. That's why we take the approach of having recognized external healthcare providers. Recognition allows us to have control over when and how a non-local institution can access a patient's data. So a patient consents to opening up their records to an institution. That patient has to give the consent on the spot, and only then that non-local doctor can access the data. And after that access, that data will not stay with the mainland institution. We will take back the recognition afterwards. So there will not be a need for the non-local institution to delete whatever data they have. But Ms. Lam may wonder, we can revoke the recognition. But that non-local doctor may jot notes during the consultation. And this goes back to the other question from Ms. Lam. When you have medical data stored outside Hong Kong, that data will be subject to data protection laws of that place outside Hong Kong. And when that medical institution deals with the data and they leak the data, they will be subject to the relevant laws in the mainland and relevant measures will apply. So when we recognize a non-local healthcare institution, we will have an agreement with that local government. We will protect personal data privacy, and the local law enforcement authorities will have the power to deal with the local data leakage and also the question on the need-to-know basis. Even with the current law, we have this arrangement in place. For the 13 healthcare professionals now, we look at what kind of information which professional needs. So the data access varies from one professional to the other. Professor Chen Wen-Kwong has talked to us about this often. For registered Chinese medicine practitioners, they can see all kinds of data on e-health. For supplementary healthcare professionals in the future, or professionals without a statutory regulatory regime, we will consider their professional functions, and they will have restricted access. So they will only see what they need to see. Next, Reverend Peter Kun. It's good to have the data sharing system, but the prerequisite will be an electronic system before you can have data sharing. But as another member said, older doctors may rely on handwritten records. So do we have a plan to draw a line? Say, when you start practicing as a doctor from a certain date onwards, you have to maintain electronic records. We're fortunate that we don't have any incident where we have lost medical records. But then a doctor may pass away all of a sudden. We would like their records to be kept, but those records actually belong to the patient, so let's bear that in mind. From what I know, for some patients, they have some very personal conditions, say AIDS or mental health problems. The current arrangement is that when the patient wants to keep the record secret, they will have to take away the health record from that doctor if the patient wants to keep this history secret. So can you let at least doctors at the A&E know part of someone's medical history that's normally inaccessible to other practitioners? So I'm wondering what we can do on this point. So 2 questions. 1, a timetable. 2, and whether you can make certain parts of their medical history accessible to some doctors. On going electronic, some healthcare professionals may not be savvy with going electronic, but our track record is not too bad. Let's look at doctors. Private practices vary in size. For clinics already with an electronic clinic management system, more than 80% of such private practitioners already have such a system in place. So for younger, newly minted doctors, we believe they are already savvy with the electronic system and they already have the system. Now, on premises, larger medical groups have well-established electronic systems. But as Mr. Tommy Cheung said, For the veteran doctors, they have decades of experience under their belt. There is a risk about their medical records. Say the doctor has an accident and some medical records may go missing. So we give support, we give assistance. We would like to have some third-party service providers that will help older doctors who rely on paper records to help convert the written records into electronic records. But we're taking things one step at a time. So we start with clinics already with electronic systems in place. We focus on those first. First, we build up a market ecosystem. And then there will be some third-party services at affordable rates. They will come to help healthcare providers who are more reliant on paper records at the moment. Now, on privacy, for more sensitive parts of someone's medical history. Reverend Kuhn proposed one way, so a patient can decide not to use e-health when consulting a certain doctor for a particular condition. But this is not the best way to go. So in our amendment, we have put forward a concept. When uploading data onto e-health becomes mandatory, the doctor will have a reasonable defense for why they're not uploading certain kinds of data. Say a patient meets the doctor at the consultation, and the patient expresses their wish in a written way that they do not wish a certain consultation to be part of the data on e-health, then that doctor can rely on this instruction for not uploading the record onto e-health. That's one more option for the patient. So when the consultation is about less sensitive things, the patient can give consent for sharing the data to the doctor. But when particularly sensitive data are involved, the patient will have the option to have special treatment for such data. In the future, we will develop new functions on the platform to help doctors manage such situations. Professor Chen Wenguang. Thank you, Chairman. I welcome continuous efforts to improve e-health. On this bill, I have some questions. The bill proposes empowering the Secretary for Health to require specified healthcare providers to upload specified healthcare data onto people's e-health account. So my question is, when will the Secretary invoke such power? And what policy goal can this measure meet? The bill will only require the uploading of specified healthcare data onto people's e-health accounts, but not all health data. Will that undermine the integrity of the e-health platform? For CM practitioners, they are playing an ever bigger role in Hong Kong's healthcare system. Our first Chinese medicine hospital will open at the end of this year. CM practitioners will also play a bigger role in primary healthcare. So it's important to foster collaboration between CM practitioners and other healthcare professionals. My question is, will we move faster in breaking down the data barrier between CM practitioners and other practitioners? Meaning, can we let CM practitioners access the healthcare records currently only accessible to other healthcare professionals? If so, what are the details, if not the reasons for that?
Thank you. 3 questions. First, usage. Second, why not all data is required to be uploaded? And 3, the access to these data by CM practitioners. Thank you. On the first question, whether when the power given to the Secretary of Health will be invoked. Now, after funding was obtained from the Finance Committee to take forward the 5-year eHealth Plus development plan, the major work in the first 2 or 3 years is to enhance the connectivity between the eHealth system and the electronic health record systems managed by individual healthcare providers. Now, by 2027, there will be substantial progress made in terms of system connectivity. At the time, by then, if the technology is matured and sophisticated, then we will see whether there is a healthy growth in terms of the data, the amounts of data uploaded by the private sector. Now, since we have connected our system with some healthcare providers on a pilot basis last year, over the past year, the amount of data uploaded by the private sector has seen an increase of some 70%. In terms of units or premises of healthcare providers with health data uploaded, there was an increase of 80%. Now, the new power proposed to be given to the Secretary for Health is based on the premise where there is sufficient systems connectivity and where there are mature technologies. And if we judge that by using legislative means, we can encourage the private sector to upload more health data, we would do so, and empower the Secretary for Health to require these data to be provided. Now, as mentioned in the bill, we will not require the mandatory provision of all health data. We will only prioritize health data types which are important to patients. There has been a lot of discussions with the healthcare sector in the past. We have also made reference to other jurisdictions where healthcare providers are mandated to upload health data by legislative means. Generally speaking, these data types include prescription, drug allergy data, pathological diagnosis, and radiology records. Now, across different medical professions, including Chinese medicine professions, these are all data with major clinical values. Now, in terms of connection and access by CM practitioners to health record, we have extended the pilot program of system connectivity to the Chinese medicine profession. So there are 2 issues to be sorted out. First, we need to break down the digital barrier between the Chinese medicine profession and the e-health system. Second, with the commissioning of the Chinese medicine hospital, there is a greater need and there will be more application scenario for CMP to gain access to healthcare records, because there will be more and more collaboration between the Western and Chinese medicine sectors. So we will ensure that on a need-to-know basis, these healthcare providers will have access to healthcare records. Next, Ms. Judy Chan. Thank you, Chairman. I think we all support the bill on taking forward the eHealth Plus vision. This is the trend. I have three questions. Now, at the beginning, the Deputy Secretary mentioned that there are 6.1 million patients registered under the eHealth, and you said that you will encourage parents to register their infants on eHealth. Is it not mandatory right now? There are lots of immunization to be done when a baby is born. So will you make this mandatory for parents with newborn babies? Paragraph 16 of the paper. On a need-to-know basis, a group of specified healthcare professionals will be allowed access to health record. The scope is quite wide. There are some 20 types of healthcare professionals with record access. Some of these healthcare professionals are not directly involved in the provision of treatment. For example, assistants and scientific officers and so on. So for these types of healthcare professionals, can we offer a lesser tier of access? Say, for the lower tier, only basic information is granted. The complete set of information should only be made available to those healthcare professionals providing direct treatment. Second question, if the bill is passed, private healthcare providers will need to employ more manpower and dedicate more resources to make the switch. So will the government help them? Deputy Secretary. Thank you, Chairman. The design of the eHealth system is based on the premise of a voluntary system that includes registration. So that's the case for infants as well. For infants, of course, they can't make a decision on their own. Well, according to our experience, if there is sufficient support, like Ms. Judy Chan said, parents or guardians of the newborn babies would prefer creating the accounts for the infants so that there is a complete set of record for the immunization. On whether we can do more or even make it a default for newborn babies to have an eHealth account, we would consider these options as well. It would be best if all newborn babies are automatically registered under the eHealth system. But still, the basic principle is voluntary participation. So that's a decision to be made by the parents and the guardians of the newborn babies. Second, the bill proposes an extended scope of healthcare professionals which are granted access to eHealth records. Now, some of them only participate in certain segments of the cure process. They still have a role to play in the care journey for the patients. So we will consider these necessities. For example, a counselor. How much information should be given to counselors for providing the counseling services? Well, they may not need to know certain health data records of the patient. So we will tailor-make the scope of healthcare data available to specified healthcare professionals on a need-to-know basis. We will block data access on a need-to-know basis. There will be a regime for continuously reviewing the access scope to ensure that the healthcare professionals have the data necessary for their services. Now, concerning support for private healthcare providers, of course, the bill will come with additional costs on manpower and technologies. Now, under our pilot scheme, we do offer financial subsidy to the healthcare providers, not directly, but via providing coordination between the third-party service providers and product developers and the healthcare providers. As I said, more than 80% of doctors in the private sector have registered under a certain form of electronic health record systems. So these are third-party systems. So in rendering these services to the private sector, the third-party service providers would have had access to e-health system. So that would impose the least financial burden on the private healthcare providers. We will continue to help the private sector sort out all the issues in the next 2 or 3 years' time. And also iron out the wrinkles in terms of systems connectivity to create a healthy ecosystem. Thank you. The bill's intent is to encourage onboarding as much as possible. Now, Ms. Judy Chan suggested that we should make it a default for all newborn babies to register under the e-health account. Now, since we have the $20,000 newborn baby bonus, can we make this an eligibility criteria for the bonus that is create an account under e-health? Thank you. Ms. Carmen Kan. Thank you, Chairman. I support digitalizing our health record system. In particular, one index to judge the smartness of a city is digitalization of health record. From cradle to grave, we are all healthcare services users, so this is important. Now, the ordinance came into effect in 2015. It has been 10 years on. But I'm pleased to see the major progress made. Since we are trying to make the government smart, I support the bill. Now, I agree with Ms. Judy Chan and also the chairman. I think we should start with the new generation. We should operate under an opting out approach. Unless the parents opt out from the e-health system, all babies should be registered under the e-health. Now, as the PAC, I have made some suggestion concerning the student healthcare program. Now, the Department of Health is still keeping students' health record in written form or in paper form. That's the Student Health Service. Now, of course, there are some merits, but it is very backward, since if you want to change an appointment under the Student Health Service, you still need to make a phone call to the department. So we should start from the younger generation. We should operate under an opt-out approach.
方面嚇。
So that's my idea. Now I turn to the PowerPoint. I welcome that because the PowerPoint really shows us what we're trying to amend. Now I'm looking at slide 4, 3,700 private healthcare institutions. So you go to a clinic, you know you are visiting a private clinic, but here it says private healthcare provider. So does it mean that we are counting the number of business registration certificates held by doctors? Is that what we mean by the 3,700 registered private HCPs? I may have missed a number or two from the Deputy Secretary. So can we have a number on the percentage of registered HCPs as a percentage of all HCPs? Now I turn to slides 7 and 8. Safeguarding citizens' right to obtain important EHRs. The health records belong to each patient. I'm looking at these two charts. Here's what I see. Now for private healthcare providers, they make up 59% of all the access to the healthcare records. But then on the right-hand side, I'm looking at the pie chart. Public healthcare providers contribute 99.3% of the records, but private providers only contribute 0.3% of the records. So patients granted consent to private practitioners to access their data. The patient may not be aware that the private practitioners who have viewed their healthcare records have not uploaded the records onto eHealth. So when the patient goes to visit a different doctor next time, the next doctor does not know what happened before. So we should do more on telling people that they have the right to their own electronic health records. My time is up, so I will save my questions for next round. So a quick response on an opt-out approach for newborns. We are actively considering this option. We are thinking about how we should approach this. We work with the Department of Health on going electronic. We're trying to go electronic with the service delivery of the DH, and where possible, we're trying to link up the DH's services with eHealth. Now, on healthcare providers, they're different from healthcare professionals. So we're talking about body corporates when we talk about healthcare providers. So it's about business registration. A registered doctor may have 2 registered premises where they provide healthcare services. So in that case, you will have 2 healthcare providers registered. But that doctor only counts as 1 user on the system. There will be some overlap. Say you have a sole proprietor who is a doctor. They run their own clinic. So it's 1 doctor and 1 clinic. The services are provided on the same spot, but we have 2 distinct concepts, providers versus professionals. Where liability is concerned, the provisions state that their liability lies with the provider, meaning the organization. The provider or the organization will need appropriate arrangements in place to make sure that the people who work there meet the legal requirements. Now, on uploading data, this asymmetry in uploading healthcare records, this is indeed a problem that we have been trying hard to overcome in recent years. Private healthcare providers deal with a much smaller amount of healthcare records than their public healthcare peers, but there has been marked increase in the healthcare records uploaded by private providers. More often, private practitioners viewed healthcare records on eHealth more than they uploaded records onto the system. But things have changed. For larger healthcare bodies in the private sector, such as private hospitals and private clinics run as part of a group, these parties are now more active in uploading data onto eHealth and connecting to eHealth. And that's also why we want to get more people to upload their healthcare records through this exercise. Now, my second question was about the denominator, meaning what's the percentage of private healthcare providers who have signed up for eHealth? What's the percentage of the registered private healthcare providers as a share of all private healthcare providers? So maybe a written reply would do. Now, only 3.7 million healthcare records out of the 4.5 billion records were uploaded by private healthcare providers. So you can see the stark contrast. Now, we will come to Dr. David Lam. The Deputy Secretary has said there has been a stark increase in the data uploaded by private providers. After a major effort to secure it, I managed to get my employer to upload healthcare records only starting in January 2024. Now I come to the point about asymmetric record upload. In the past, we could not upload data in the private sector. Under the new proposal, when you have a joining consent, private hospitals will have to upload the records. But the private doctors may not be able to access those records, say the doctor has prescribed the drugs. But the doctor is not aware that the patient has a drug allergy. You have another form of asymmetry. Can we ensure access to data that the doctor has uploaded, because sharing consent and joining data are different? Now, 13 professionals can access eHealth. Chiropractors are wondering when they can access eHealth. So can we have a plan for other healthcare professionals to access eHealth? And do we have a way to protect patients' data from third-party access? Say, insurers require patients to sign a consent form when a policy is taken out. And here, the doctor has a part to play, because here the patient is a data owner, and the data user will have to provide information. But a doctor may be asked whether that patient has other service providers or other diagnoses by the insurer. The doctor sees that on eHealth. I want to read out something from my own health insurance policy. You may have signed it, but you may not be aware. I hereby authorize that whoever knows any employer, any Western practitioner, any insurer, any other organization or person who knows my health care history can provide my medical record to a certain insurance policy. Even if I die, even if I'm totally disabled, this authorization form remains valid. And any assignee of this consent form will be subject to this authorization form. The original and photocopy of this consent form will be equally valid. How do we protect insurance policy holders or prospective policy holders? And when I take out a health insurance, and the insurer asks me to appoint that insurer as an authorized person, what to do? So, two questions. One, will a private doctor be unable to access data because of the issue with joining consent and sharing consent? And the other question was about insurers. Mr. Sam Ho. First of all, I want to thank Dr. Lam for taking an active part in our pilot schemes, and also Dr. Lam gave us much feedback to help us do better. We will sort out the issues we have spotted, large and small. Otherwise, we won't be able to complete the task of creating complete health records. So our gratitude goes to Dr. Lam. First, on this asymmetric access to data, encouragement is the way to go as we try to find the right balance. Dr. Lam will know that we have plans to help people tell which providers are on e-health. Healthcare providers can also tell patients that they need access to healthcare to provide better healthcare services. Achieving this will lead to better outcomes. But to get there, we will first have to talk to patients and the healthcare sector. We will have to coordinate between different parties. We will first have to champion this measure, and we also have to facilitate this. And we're happy to work with different professional bodies in spreading this message. On insurance, I want to discuss the intention behind authorization. Say a patient cannot look after themselves, they need a carer to look after their medical needs. In this case, the patient can authorize the carer, or if it's a case of a minor and the minor needs their parent or guardian to manage this person's medical records, and that's why you need authorization. By authorization, we're not thinking about commercial bodies or someone from an insurer. This does not fully address the question raised by Dr. David Lam. Dr. Lam's question has to do with the purchase of insurance products on the market. A service provider or an employer or a third party may require people to provide information, or they may require information from this person's doctor, information on diagnostics. And that information may come from someone's personal account on e-health. We have stringent controls in place. Such that any non-medical third party seeking to use the record will have to go through this patient or a healthcare professional working with the patient. as we have more comprehensive records on e-health. We will try to work out an approach that respects patients' privacy and also doctors' professional autonomy, while also striking a balance that also works for the market. We need an ongoing conversation about clinical data, how the clinical data should interact with the non-medical sector. We're happy to talk to the relevant sectors about that.
Thank you, Ms. Rebecca Chen. Thank you, Chairman. I'm pleased to hear the reply from the administration. According to many doctors, it is not that they are reluctant to come on board the system. It's just that they lack the technology to do that. Now, after the passage of the bill, if a professional medical body contravenes the law, there will be an offense. Now, even when prosecution is taken out against a medical group, the qualification will not be affected, but it will have an impact on their reputation. Now, whether the healthcare provider can provide the data depends on the consent of the patient. So some patients will opt out when they don't want the doctor to see the medical record, but then they may grant access to another doctor. So do they have to cancel their registration and register again afterwards? How does that work? Now, about cross-boundary sharing of healthcare record. Now, like the elderly healthcare voucher scheme, there are many healthcare service providers on the mainland recognized by the Hong Kong government. Now, under the bill, subject to certain conditions and the recognition, non-local healthcare providers will be granted access as well. So what are these conditions? Will you notify the public of these conditions by way of Gazetted? Now, there is a piece of local legislation specifying that for non-local healthcare providers who are not subject to a regulatory regime or this bill, the best that the government can do is to revoke their connectivity or their access to e-health records. So what if these healthcare providers commit egregious offenses like selling patients' data to third parties? What can the government do to ensure that that would not happen? Now, according to a survey in December 2023, there were 12,500 doctors with access to e-health, but there are only 760 dentists with access to e-health data. Why is there such a low onboarding rate among dentists? Now, for Chinese medicine profession, that's another matter, but why is there such a low onboarding rate among dentists? 3 questions, Deputy Secretary. Now, patients or members of the public registered under e-health on a voluntary basis. So when registration is revoked, then according to the law, we have to delete all identifiable data on the system. Now, for the case mentioned by Ms. Rebecca Chen, if a patient chooses to cancel the account and then rejoin the system, then it will render the health record incomplete. So if there are very sensitive data which a patient does not wish to share with a particular doctor, then we will provide a channel under the bill for the patient to deny that particular doctor access to their medical record by way of a written statement. That is not very convenient, but at least that is better than having the patient cancel the account and create the account again. Second, concerning cross-boundary sharing of health record and also protection of personal data. The protection extends beyond this bill. This has always been a potential risk in terms of cross-boundary record sharing. Under our pilot scheme for data sharing and also the elderly healthcare voucher scheme, the idea is to offer more options to patients on the mainland. So there are already medical health records stored in electronic health record systems across the border. So if there are abuses of these data, we have to rely on our counterparts to enforce the law. So these law enforcement agencies would be law enforcers in the mainland concerning personal data and personal privacy, and also counterparts of the hospital authority on the mainland. Now, in terms of transmission of personal data, I think we all know that the mainland has a much more stringent requirements on cross-boundary transmission of personal data. Now, on our side, we do not have extra territorial power, but we believe that there is already sufficient protection on the mainland to protect personal privacy. So that's a major safeguard for cross-boundary sharing of record. Now, about dentists' onboarding rate on e-health. There is a lower onboarding rate, but that is going to change because there's going to be a module for dentists in the future under e-health. There will be infographics showing the health situation of a patient's teeth. Now, we do offer a certain amount of subsidy to dentists for registering under e-health. Now, according to our latest figure, more than 60% of dentists in Hong Kong have joined e-health, so the progress is significant. Mr. Edward Leung, thank you, Chairman. We support the electronic health record sharing system. Now, my question is, a patient in the public hospital will be given a form to join the e-health system. If a consent of joining is given, then all records will be shared. Of course, the patient can choose not to join the system. Now, after several years, if the patient has to undergo an operation in the public healthcare system, but the operation was a failure, and he blamed it on the lack of information on the e-health system. And when the patient was told that he wasn't presented with such a form, and it turns out that he did not tick that box, then will that become a gray area or a potential loophole for litigation that may cause significant confusion? So how can we ensure that doctors are protected against this pitfall? Deputy Secretary, Mr. Edward Leung's question is similar to Ms. Carmen Can's suggestion. It did occur to us that for patients receiving services in hospitals and the Department of Health, we may have these patients enroll under eHealth on default. This may be the direction forward. Now, for newborn babies, that's another matter. For adult patients, there are more considerations. Let's say there is a patient in the specialist clinic under the HA who insists not to enroll in eHealth. Then should we deny service to this patient, or should we treat this patient differently? That's treacherous water. So the idea is to make the onboarding of eHealth automatic and convenient. We need to tell the public clearly that enrolling in eHealth is very beneficial for the patients. So they should think carefully before opting out of the eHealth system. If the patient still insists to opt out from eHealth, if that is a patient in the public healthcare system, then even without an account on eHealth, there would be a set of comprehensive record within the hospital authorities' health record system. So if the patients later decided to create an account under eHealth, then those previous health record would be transferred into the account. So of course, there would still be a gap, that is, the medical record of the patient in the private healthcare system. For that part of the medical history, the patients may have to renew the record in the eHealth system subsequently. So is there not an opting out option on the form given to patients in public hospital? Now, one way of joining eHealth is by way of the form. Another method is to create an account on your mobile phone app. There's also submission of the form by way of by post. So there's not a form for the patients to sign to opt out from eHealth. Ms. Jovi Chan. Thank you, Chairman. First of all, I support the amendments bill. Since the eHealth was established in 2015, there have been many changes. For example, we have the DHC. There is more cross-boundary medical needs. Now, I have paid a visit to the mainland medical institutions recently, so I support cross-boundary transmission of health data. Now, after the passage of the bill, there will not be a duplicated consent system. Simply by joining will signify consent for sharing data. Now, it will help boosting the onboarding rates of eHealth and ensure portability of health record. It will also allow doctors to have a clearer picture of the patient's medical history and also better management of the health record by patients. Now, as the Deputy Secretary said, the demographic structure of e-health registrants is an inverted pyramid. There is very low onboarding rate among minors. So how can we encourage parents to sign their children up for e-health under the new system? Now, can we have an alternative pathway that is approaching the parents in kindergarten and child care centers? Parents trust teachers, so maybe we can approach them from schools. Now, in terms of non-local healthcare providers applying for recognition, how fast will the process be? Sometimes they urgently need the healthcare records, so is there an expeditious pathway for them to get recognition? Thank you.
2 questions. Thank you. On the registration of younger persons on e-health, we will look at the opt-out approach. On top of that, on whether we can foster or promote e-health registration in other scenarios, say a child gets inoculated at school, or a younger child goes to the maternal and child health center. These scenarios are good opportunities for us to persuade a child's parent or guardian to sign up their child for e-health, so we will work on that. On promoting e-health, we have launched a scheme this year. We are giving out gift packs for newborn babies. I've heard that they are popular. So we have these measures that are a form of soft approach, and we're also working with schools. We will do what we can along those lines. On recognizing non-local healthcare providers, we make a distinction between local and non-local healthcare providers. For non-local institutions, they first have to be. Now, local institutions have to apply to be part of e-health. Now, for non-local institutions, the government has the control. So we don't just let any non-local institution to sign up. We have stringent controls in place before records go out to non-local healthcare providers. So we need to be familiar with the institution first. We have to be confident in the security measures in place at that institution. And when things go wrong, we need some sort of agreement in place with the local government of that non-local institution. We need all these things in place before we recognize that institution. So the government will be in control of the accreditation scheme. This is different from healthcare vouchers, where an institution can just apply to be part of the scheme. So my question is, will a non-local institution already covered by healthcare vouchers have an easier time getting the recognition? we work with the Mainland Health Commission. We talk about the institutions that we can cover under the healthcare voucher. And then when it's appropriate, we cover that institution under the healthcare voucher. So it's not up to each institution to apply to be part of the healthcare voucher. There are institutions that look after patients from Hong Kong, and they're more familiar with how the vouchers work. In those cases, those institutions are in a better condition to be covered. We still have to make sure that those institutions have their security measures and controls in place. Not every institution is equally savvy with the technology. Some are ahead, others need more work. We are not limiting ourselves to healthcare providers that are already part of the current healthcare programs. Recognition does not just go out to institutions already covered by existing programs automatically either. Mr. Chen Pui-le. To make the electronic healthcare record sharing system work, we need health records that are already uploaded. I know larger medical groups have gone digital, but for smaller clinics or sole proprietorships, do we know if those smaller practices have already gone digital, or do these clinics rely on written records? When we say uploading healthcare records, can we also upload images on top of text? Say someone has received an ECG or someone got an X-ray. Can we upload all such images onto eHealth so that a doctor can see them? My next question is, how do we ensure the accuracy of the uploaded records? Will there be a mechanism to verify the uploaded records? Will the system be able to tell that whatever you have uploaded is inaccurate right away? How do we ensure the accuracy of the uploaded records? Do we have a way to verify the uploaded data? So 3 questions for the Deputy Secretary. Now for doctors, more established medical groups are more savvy with digital systems. $10 to 20% of medical practices have not yet gone digital. So that will be the tough nut to crack. For these practices, they have yet to go digital. And these practices stick to the old way of doing things. We need to help them keep up with the times. And that will mean more work. And we also have to keep the costs manageable. So that's something that will require further effort, but they are not the majority. Still, this minority needs attention. We are aware of that. Now, on uploading images. Healthcare professionals can share images on eHealth. So a patient got an X-ray or some kind of scan at hospital A, someone at hospital B will be able to view the images through eHealth. On the eHealth app, We want to let people access their own pathology test and diagnostic imaging reports too. Sharing medical images matters even more than sharing the basic data. On the accuracy of data on e-health, a healthcare professional uploads data onto the platform. The record goes to the personal account of the patient. When a patient thinks something is off with the medical records uploaded, there are provisions to address that. The patient can request correction or removal of inaccurate records. We verify the information first, and that means we verify the details with the healthcare providers, and if correction is needed, we will do that. We do spot checks as well. Now, we have no idea what people's health conditions are, so we cannot do spot checks. Without knowing someone's health condition, we cannot tell whether information is harmful to e-health. The system allows people to upload information. If they upload virus-infected files onto e-health, or they put their private photo album onto e-health, we will be able to tell right away that the details have nothing to do with healthcare. We can remove the files to maintain the integrity of e-health. Next, Ms. Carmen Khan. My question has to do with streamlining the consent mechanism. This is a key part. As Dr. David Lam said, we need protection for both patients and healthcare professionals. A patient consents, the healthcare provider will have to think about whether the patient agrees to uploading the records. So I wonder what enhancements we're introducing to the joining consent and the sharing consent. Now I turn to the PowerPoint slides, slide 10. It's important to ensure people have access to their electronic health records. Making it easier for people to use their medical documents is one aspect. There will be referral letters, medical certificates, etc. So do we have a timeline on when these steps will be taken? We're including healthcare providers not registered on e-health. The Secretary will designate a commencement date, and from that day onward, those healthcare providers not on e-health now will have to follow the new arrangement, because this will be a key step for the integrity for our e-health system. Now I have a question about the technical feasibility, and it's on slide 11. People want swift results, but private healthcare providers may run into technical problems. So what assistance are we giving to private providers to overcome those problems? Do we have some kind of QMark, quality assurance scheme, so that people can tell that when they visit a certain clinic, their records will be uploaded after a consultation. That way, the healthcare providers will also have an incentive to upload the records. You don't have to wait till you make those providers upload the records, because in those cases, the providers that upload the data will get more business.
Deputy Secretary, thank you. Under the existing consent system, there is a two-tier consent, but we are going to change that. That there will be the joining consent, that is agreeing to create the account under eHealth. Now, under the present system, only the medical record with public healthcare providers would be provided into the account. For data kept by the private sector, sharing consent has to be given. So for the sharing consent, it is two-tiered. It consents to a private healthcare providers, a private healthcare provider to have access to the healthcare record and then provide the medical record into the account. Now, under the bill, we propose a change to integrate the consent for a private healthcare provider to provide information into the health accounts, eHealth accounts, into the joining consent. That is, with a joining consent given, a private healthcare provider can provide healthcare data into the eHealth account. Now, the sharing consent will only apply to granting of access to eHealth record to private healthcare providers. We think that would be easier for the public to understand the consent system, and it will also enhance the comprehensiveness of the health record. Some clarifications are needed. So parts of the sharing consent is integrated with the joining consent, empowering healthcare providers to upload health record into the account. But that doesn't mean that the healthcare provider has to upload the data. So as a patient, with consent given to uploading, can I also request the healthcare provider to upload my data into the system? Then when I receive healthcare services in the public healthcare system in the future, I can be sure that my record has been uploaded onto the eHealth system by the private healthcare practitioner. So that involves two steps. First, as mentioned by Ms. Carmen Khan, on a voluntary basis, we will make sure that the public knows which healthcare providers have signed up or enrolled under the eHealth system. So we will have a Q-mark quality assurance system in the future. Gold, silver, and bronze medals will be awarded to healthcare professionals depending on their participation level in eHealth. That should happen in the next 2 or 3 years. The Q-mark assurance system is an important component of our system connectivity efforts. Now, in the bill, we will empower the Secretary for Health to require provision of health data That mostly applies to important health data. In terms of when the power will be invoked, now we think after 2 or 3 years' time, when most systems have been connected and when the coordination work is completed, we would consider mandating provision of health data under e-health. When that happens, like Ms. Kaman Khan said, whether the healthcare providers has registered under e-health, the Secretary for Health still has the power to require provision of health data by that healthcare provider. Now, simply put, all the tools are in place. There are sufficient tools for achieving the 8 strategic directions. Thank you. Mr. Holden Chow. Thank you, Chairman. I have 2 questions. I think the administration has answered part of my question. I presume that major private hospitals or private medical groups have the manpower and financial resources available to achieve meet the requirements. It shouldn't be a problem. On the other hand, it would be much more difficult for smaller practices comprising only 1 or 2 doctors and nurses. What you are asking under the bill takes substantial resources. So for these small practices, which are essentially one-man bands, what support will be given to these clinics or practices? And also, how long do you expect them to complete the conversion? Now, that would be a transitional period where some of the records have been uploaded, but some have not. So how will you address the difference and how will you resolve this gap? Now, paragraph 12, cross-boundary data sharing. The focus of the paper is more on authorizing mainland healthcare providers to use Hong Kong citizens' data. What about the other way around? For Hong Kong citizens residing on a long-term basis in the mainland, they must have received healthcare services in the mainland. So how can we ensure that the health record on the mainland can be accessed by recognized medical bodies in Hong Kong? I think some of the questions have been answered, but maybe the administration can offer a brief answer on support given to smaller practices to meet the requirements of the bill. Now, the doctor may be willing to share the record, but they may need help. So what help will be given to them? Second is about gaining access to healthcare record held by mainland healthcare providers. Thank you. For small practices, yes, they may be less ready to embrace the technology. And also, but on the other hand, the complexity of the medical records they hold is much less than those held by larger hospitals. For small practices in a housing estate, well, they will be mainly dealing with episodic diseases. So for those small practices who need to catch up in terms of technology, we may offer them help by 2 channels. Now we may create a dedicated page for these smaller practices to input the health data. Now, if they still find it too difficult, we may engage third-party service providers to help them. Now, we will sponsor these smaller practices to engage help to digitalize their record and upload them onto eHealth. Now, how can we keep the cost low and make it efficient? We will have to consult the trade and discuss it with the commissioner. Now, in terms of cross-boundary health record, on one hand, Hong Kong citizens receiving medical help or medical services in the mainland, they can have their health record uploaded onto eHealth with the established channel. On the other hand, there is a more complicated scenario. As mentioned by Mr. Holden Chow, there are many medical institutions in the mainland. Some are recognized by us, some are not. Now, the situation is different from that in Hong Kong, because in Hong Kong, we have a common electronic health record system in Hong Kong. In the mainland, there is not. Now, even for Shenzhen, which is one of the most advanced cities in the country, the mechanism for health record sharing among different healthcare providers in the city is much less comprehensive than ours. Now, in the future, there may be a regional electronic health record system in the mainland, for example, an eHealth for Shenzhen. That may enable sharing of healthcare records among different medical institutions in the same city. Now, if we can ensure that there is sufficient safeguard in place and that it is technologically feasible, we can connect that official platform with our eHealth system to ensure bi-directional sharing of data. But we have to wait and see, because that depends on the level of sophistication of the eHealth record system of those places. So in terms of recognition, we can offer recognition to an individual healthcare provider, or we can recognize the entire eHealth record system run by the administration of that place. Now we have to keep the time strictly. Next, Dr. David Lam. Thank you. About the offense of failing to comply with the enforcement notice. Now, if a healthcare provider is being sued in court, there are 2 reasonable excuses. One, the patient denies uploading of the data. The other statutory defense is that due diligence has been made to prevent the commission of the offense. Now, why don't you ask the healthcare provider to offer this excuse before going to court. It's just like that. You should make your case to the police officer before they give you the ticket. Now, the administration should have made clear that under certain situations that healthcare providers can be exempted from the duty to upload the healthcare data, including that a patient denies or prohibits them from uploading the data. So like the mandatory reporting regime for child abuse cases, we should make reference to that ordinance so that the healthcare provider can put forward these excuses before they are sued.
I have some questions about the nitty-gritty. In the future, the healthcare providers will have to upload the records if there's an order from the secretary and it's written into the schedule. But there's nothing on third-party organizations say the system is down, the organization cannot upload the records, and then the HCP is held responsible. So we will be holding the organization responsible in such a case. Mr. Sam Hui. Thank you. On issuing an enforcement notice, we're thinking about how this will work. Say a patient complains that the doctor failed to upload the record, but it turns out that the patient has instructed the doctor not to upload the record. There will be a button on the system. For us to tell that a patient at some point has asked the doctor not to upload the record. That will help us tell whether a complaint is substantiated, but other things may happen. Maybe it's not the case where the patient does not want the doctor to upload the record. Something beyond the control of the doctor has prevented the doctor from uploading the record despite the doctor exercising all due diligence. Those facts may not emerge in full during the investigation because in such a case, we don't get to talk to the doctor for an in-depth discussion. Dr. Lam's point is whether we have more stringent controls in place, such that before we issue an enforcement notice, we already consider whether the doctor has exercised all due diligence. Dr. Lam's point is whether we can consider whether due diligence has been exercised before we issue an enforcement notice. And we are actually thinking about this. We're thinking about possible changes to see if we can make this arrangement clearer. And when we have a clearer idea, we will brief members of the Bills Committee on this. Now, on the other point about practicality, it's about third-party service providers. Those providers are not directly regulated by this bill. We may need to regulate such providers. The regulation may happen through legislation or some sort of collaboration. We can explore that, but that will not be within the scope of the current exercise. we will need more time for policy discussion. So we will cover the next two members and then we will adjourn the meeting. We'll come to Ms. Chen Haoyan. My first question is about mandatory uploading of specified healthcare data. The Secretary for Health will be able to mandate the uploading of such data. Can we make sure that each time the Secretary mandates such an upload, the matter comes to LegCo for scrutiny? Now, I come to enforcement. We also have to consider whether uploading the data is something the healthcare professionals can do. So my question is, how many officers are there at the eHealth office? I think you have just a few dozens. After the bill is enacted, will the government need dedicated investigators? When you get a complaint about a doctor failing to upload the records, you will need enough manpower. So how many extra officers will you need for investigation? My third question has to do with electronic medical documents. The future eHealth platform will also contain medical documents. There will be requirements on format. What sort of documents can only be issued through eHealth? What documents will be covered in the first phase? Say, will they be doctor's notes? So we will have to tell the public about that. What will the timetable look like? If this bill is enacted with member support, we will set out a schedule. We will empower the Secretary for Health to say in that schedule what sort of record needs to be uploaded onto eHealth. Every time something is added to the schedule, we will be amending the schedule, and that will mean subsidiary legislation. And that change will go through the negative vetting procedure at LegCo. So we will need member support during that process. So the matter will come to LegCo. On manpower, we don't have any specific size in mind. Now we have an office on eHealth. We have our existing establishment. We have officers addressing complaints and inquiries. In the future, we will be mandating the uploading of records. That means more complex complaints may come along. We will consider the manpower needed, the resources needed when enforcement is needed. I'm sure members will ask us about the manpower plans we have, but you need a preliminary plan. We need a rough idea of how many officers you will need, because you will be in charge of investigation. So a rough idea of the establishment, you can give us the details at the next meeting. We can prepare a preliminary plan. You don't have to give us exact figures. Give us a sense of the magnitude. Is it going to be dozens of officers or over 100? You will need to enforce the law. You have to investigate the doctors and nurses, whether they have exercised due diligence. You need someone to investigate the cases. You cannot just rely on your existing officers. Give us a sense of the size of the manpower needed. The third question, electronic medical document. After the bill is enacted, eHealth will be used to issue documents that are equally valid as written documents. There's a provision that certain documents can only be issued through eHealth in the future. On what kinds of documents will be covered under this approach? Will they be medical certificates or AMDs? or prescription histories or referral records. We're looking at these options. But these documents are subject to different pieces of legislation. We have to examine these options in detail before we decide whether to specify them as documents under this bill. Ms. Carmen Khan, I want to follow up on a question from Dr. David Lam. Before we come to the clause-by-clause scrutiny, we want to get two things clear. First, specified healthcare providers. The paper also mentions healthcare professionals. We will be regulating healthcare providers on the future platform. Even sole proprietorships will need a business registration certificate. But then for the 13 or 18 kinds of healthcare professionals, we're talking about individuals. So different rules will apply. For healthcare providers and healthcare professionals, we need to be clear on this. And then we come to responsibility. When you take out a professional insurance, is the insurance taken out on the organizational level or on the individual level? And when medical negligence occurs, who will be subject to discipline? The PowerPoint slides, there are two steps. First, the commissioner issues the enforcement notice, and when the professional ignores the notice, they may incur a fine. So my question is about where the liability lies, Mr. Sam Ho. Under this bill, the healthcare providers will be regulated under the bill. A healthcare provider also needs a code of practice. To ensure that the professionals working at that provider meet the requirements. The liability rests with the provider, the organization. But when the provider is also the professional, that professional will be held liable. But the penalty will not affect the practicing qualifications of the professional. When the commissioner has reasonable suspicions and then they issue an enforcement notice, and then the healthcare provider fails to comply, I will need to extend the meeting by 15 minutes, and then the provider fails to upload the records. The commissioner can issue a fixed penalty notice. The enforcement notice will remain in effect, and when the provider fails to comply with the notice, it doesn't matter whether the fine is paid, the commissioner will be able to take that provider to court. That means prosecution. And then the sentencing will be up to the court. The fine handed down by the court will be higher than the fixed penalty. So that's roughly how it works. It's the provider that will be held liable and pay the fine. And then depending on whether this is a sole proprietorship, we will be able to tell whether the individual will be held liable.
Chairman, may I invite the DOJ or the legal advisor to weigh in on this? Now, according to the law, healthcare provider is someone who provides healthcare services. But for practices with only one doctor, they are also the licensee of the business registration. So the liability will still lies with the doctor themselves. So I think both the healthcare providers, doctors, and patients should be clear about this. The law may change the ecosystem. For one-man practices, because of the additional liability to be borne by them potentially, they may choose to change the operation. Yes, that's our design. So can I confirm with the DOJ as well? For a doctor owning their own practice, they will have to be liable for the offense. So in terms of liability insurance, now both the professional himself and the medical institutions have to take out liability insurance for that. We will provide you with an answer the next time. Thank you. So that concludes today's meeting. We will continue with the policy discussion next time. Next meeting is set on Tuesday, 29th of April, 10:45 a.m. to 12:45 p.m. A notice will be sent out by the Secretariat later. Thank you so much.